Welcome, welcome. Welcome, everybody. Love seeing you every month. We'll give a couple of minutes. Let everybody join. Okay, so let's see. Who do we have? Hi, how are you, Roma? Thanks for putting in the chat. Everybody knows they should put their names in the chat, and that way we
Hi,
can
Doctor.
say hello
Good
to you.
afternoon.
Hello. Hello, Joyce. Great. All right, so let's see. Yeah, we have a whole bunch of people. Hopefully more of your friends will join soon. But I think, oh, okay, good to see you. We have Cecilia and Maritas and Chanel. And I see lots of faces looking very eager to learn today, eager to participate, right? Okay, so I'll go ahead and get us started with the beginning logistics because that always takes a little bit of time. So, okay, well, welcome to our care home, Echo, where you get free CME, free continuing education from the convenience of your home, the opportunity to talk, learn from each other, ask all your questions. So really glad you're here. And again, thanks to Aloha Care and United Care for helping to sponsor these series. Just a reminder that for case presentations, do not share patient names, birth dates, or anything like that. Your questions can be anonymous. If you are feeling shy of typing your questions in the chat box, you can certainly type it in privately to Juliana. And she will read your question out loud without mentioning your name. And so, yeah, these ECHO case discussions are not official doctor consultations, they're for education only. And don't forget to enter your name and others joining the session with you in with your computer screen today. Just you see everybody in the chat box putting in their names and saying hello. You guys can do that. Everybody do that. That would be great. And of course, don't forget to click on the mute button when you're not speaking and unmute if you want to speak. We love to hear your voices, actually. All right, next slide. Okay, and today we are doing the fourth part of the What Matters series, and we're going to talk about care plans that matter. Next slide. And just a reminder, if you want to receive certificates of attendance, just after registering today, just complete the evaluation form. And yeah, you know the deal. You've been doing this really well. Next slide. And I just want to acknowledge our hub team here. We have, oh, is Juanette here today? Want to say hello? Or Maribel?
Hi, everyone.
Hi, good to see you.
Everyone. Good to see you again.
Good. And we have Juliana. Want to say hi?
Hi, everybody. Thanks so much for joining us today.
And she's the one to text you privately if you have questions. We want to be anonymous. Yep. And then Layla Ventar. She's from United Healthcare. Hello, Layla.
Hi there.
Good to see you. Next slide. Okay, and today we have a guest speaker. We have Dr. Karen Lubomir, who's an MD and a dentist too, from the Department of Geriatric Medicine. And she will be doing the talk today. All right, so just to start off, just because we have to remind ourselves every day to take care of ourselves, right? We're no good as caregivers if we're too stressed out and we can't take care of yourself. So just reminders as part of wellness, part of rejuvenation and restoration, right? Make sure you find time to rest, not when you have time, because we'll never have time, right? But you have to schedule it in sometimes, right? Put it in there and block it off. And then restoring. So even if you don't make more time, if you do random acts of kindness and things like that, that can often go a long ways to boost your well-being and increase your sense of faith in humanity. So doing things like that and having your whole team do that for each other, that can be quite restorative. And then also the importance of creativity, having fun in everyday life. You know, don't be afraid to be a kid, right? And be a little mischievous, a little creative, do small things, create little new things each day. Won't increase your time, but it will increase your sense of well-being. And then, of course, connecting. There are special relationships that we should never let fall by the wayside just because we were too busy. So these are just reminders for wellness. So important to put back into your life. So choose one for today, for tomorrow, and go for it. Because we care about you as caregivers. And you have to, if you're not taking care of yourself, who else is, right? You gotta do that for yourself because you're worth it. Okay, so if people want to put in the chat box some ideas that they have been taking care of themselves, you can go ahead and do that and inspire everybody, you know, even as we're going through the talk. Okay, next slide. Okay, little COVID corner here. Next slide. This is just where we are right now. Our infection rates are, you can see, have dropped way back in March. It was really looking good. And then all the masks came off and now the cases are rising again. And you can see that percent positivity rate is getting up there like 16.9% at this point. And of course, that's probably an underestimation because nobody's really reporting it anymore. Everybody's just doing home tests. And also important thing to note is that hospitalizations and ICU admissions for COVID are now on the rise as well. So yeah, we have to start being careful again. And although masks are optional, and it's probably still a very good idea, especially where we are right now with the population that we're caring for. They're still very vulnerable. Next slide. And no surprise, we are still in a very high transmission area. And new hospital admissions, 7-day moving average. So that's going up as well. You can see that. I know I mean, we're actually not doing too badly with regards to vaccination. I mean, most of our eligible population has been vaccinated, but a lot of people actually have not been going on to get their boosters. So that's probably something we should continue to encourage as the time passes and the vaccine strength seems to be waning. Next slide. Okay, so at this point, it's almost inevitable, right, that somebody's going to test positive for COVID. So this is just a reminder, and this is actually from a CDC fact sheet. So, you know, we'll put it in the chat box. I'll put it in afterwards, so you can just go click on it and find it, and you can just print out these infographics. But yeah, so whether or not you've been vaccinated, whether or not you have symptoms, if you test positive for COVID, you are contagious. And so you need to take steps to protect everybody else. So stay home, wear a mask, stay 6 feet apart, wash your hands, don't share personal items, stay separate from people and pets as well. And if you have a fan, open all the doors, all the windows, blow the fan outside, or use HEPA filters, and do what you can to prevent the spread of COVID within your household. Even if you are in quarantine, even if you have no symptoms. Next slide. And this is a recommendation. So if you do have COVID, this is for the general public. Isolate, stay at home for at least 5 days. Do another self-check, right? Test for COVID. And if you have symptoms, of course, you need to continue to stay home. But if you are free from symptoms, you can get out. However, you're going to still need to wear a mask around the public for 5 more days, because 10 days is the incubation period, and also the time you can still be transmitting. So take care. Next slide. And if you've been exposed, you've been a close contact, even if you didn't test positive, there's a 10-day incubation period. So you have to be very careful. Still, you can still pop up. So to quarantine yourself, 5 days, at 5 days, test again. And at 5 days, even if you don't have symptoms, test it again, because it can turn positive later on. Obviously, if you test at 5 days and it does turn positive, then you need to continue to isolate. And of course, no traveling for 10 days. Next slide. So yeah, so what about COVID in high-risk congregate settings? That is care homes, nursing homes, assisted livings, all those kinds of places where lots of people come together. If you cannot cohort, that is, try to group people together who have COVID positivity and have like COVID units like nursing homes can, larger ones can, then you should probably have the facility do a 10-day isolation period, so that you're not spreading it unknowingly to the outside. So, and of course, during periods of critical staffing shortages, you may need to consider shortening the isolation period to allow your staff to work as long as they're well enough to work, but you should consult with the state or the DOH, because they will tell you, how to balance it. But probably the way they're going to balance is basically ask you to wear PPE and a good, well-fitting N95 mask to prevent yourself from either getting it or spreading it. So everyone who lives there should wear a well-fitting mask inside the home and limit close contacts. So if you can, and I know it's really hard, one caregiver for the infected person instead of taking turns, or at least take turns with only one other person, to minimize the potential for spreading. Next slide. So what happens if you do get COVID? Of course, monitor for symptoms, for fever, cough, shortness of breath, things like that. And of course, get emergency medical attention if you have trouble breathing, or you have pain or pressure in the chest, getting too sleepy to stay awake, or if your lips are turning blue or your nail beds are turning blue and you're not oxygenating well. Those are obviously emergency situations. Next slide. But more often than not, especially if you've gotten the vaccine, hopefully it'll be mild symptoms. But even if you have very mild symptoms, if you are at high risk, or your residents are at high risk from getting sick and they test positive, then you should go ahead and get tested with a PCR test, not a home test antigen, but a PCR test as soon as possible after the symptoms start. What we mean by high risk are folks with cancer, stroke, lung disease, liver disease, diabetes, other disabilities, including those who are ADL dependent. That's like pretty much everybody that we're taking care of. That's why they're with us. Heart conditions, HIV, smoking, being overweight, pregnancy, and anyone with on steroids or immunosuppressive drugs. These are all people at very high risk. And if they test positive, whether or not they're symptomatic, should get a PCR test. Next slide. And what do you do with that? Contact your healthcare provider right away. And the treatment must be started early in order to work, right? Because you want to hit the immune system and boost it up as early as you can to fight off the infection before it causes too much inflammation in your body. Next slide. So currently, the treatments that we're talking about, if you get those symptoms early and you're not sick enough to be hospitalized, are oral antiviral medications like Paxlovid. You've heard of that. And we have monoclonal antibodies. That's the telovimab, big mouthful to say, which is an IV injection that goes through the IV just one time and then you're done. The Paxlovid is a pill. Actually, it's like 5 pills that you take twice a day for 5 days. So need to talk to your doctors about this. There's another medication too, another antiviral called Lagevrio. And that's just another option as well. And just so you know, there is a limited supply in the state. And so in some sense, the choice may depend on what's available as well. But the important thing to do is get tested. And the only way you can get the treatment is if your PCR test, you have a positive PCR test. Okay, so next slide. Okay, so now we're ready to talk about what matters and care plans that matter. So with this, I'm going to hand it off to Dr. Karen Liebermeyer. Thank you, Karen.
Thank you. Welcome, everybody. I'm happy to be here. Thank you, Dr. Wen, for that really thorough review of what to do. We all need to be reminded, and when it happens, right, be ready. So today we're going to finish our series in about what matters, and it comes up a lot when we're looking at the care plans for residents that reside with us. So I want to go through a case. He may or may not be recognizable, parts of him recognizable to you. Some of you've met before, had under your care. So let's start out by meeting Mr. Tayana, an 87-year-old divorced male, Puerto Rican and Chinese heritage. He became a resident of your foster or your care home due to progression of his dementia. He was acting out, he was incontinent, he started falling down, and the family just couldn't manage these conditions. Other medical conditions, common as people age, accumulate. So things like he had high blood pressure, he had COPD, and he still liked to smoke 1 or 2 cigarettes a day before he came to you. He also suffered from reflux, constipation. He had a lot of arthritis in his knees and one of his shoulders, his diabetes, and notably he had lost about 10 pounds in the 3 months before he came into under your care. Next slide, please. Social history, he was divorced from his wife, the wife of his 5 children, from whom he was estranged from all his children, except there was one daughter who had been his primary caregiver for about 4 years before being admitted under your care. He's a high school graduate, and he was a retired construction foreman, used to giving a lot of orders, and he also had a history of heavy alcohol use. His parents were now deceased. He was the oldest of 8 siblings, 2 of which are alive, and lived on Oahu. Next slide. So upon admission, here's what you found, what he was like at home. So what mattered to Mr. T? I like to have a smoke. He also liked to eat late lunch and have a Pepsi every day. His daughter said, you know, we just want to keep him happy. We don't want it to cause too much problems for him. So basically, we just give him whatever he wants. He's got a list of medications, rather long, Miralax, you know, for his constipation, famotidine, which helps with reflux, metformin for his diabetes, Doctazate also to help with his constipation. He was also on an inhaler, twice a day scheduled. He was on glipizide, which also treats for diabetes, albuterol inhaler if he needed it for wheezing. And it looks like he has some Tylenol. It's falling off the bottom of my screen. But as I recall, he would take that as needed for pain. Next slide. Under mobility, he was supposed to be using that front wheel walker, but he didn't like it. He didn't remember, and he'd rather just hold on to the furniture, something we call furniture surfing, hold on to a wall, the furniture. And unfortunately, he'd had 3 falls in the month prior to admission to your setting. He was able to feed himself, but the food didn't always stay on the implement, right? The spoon, it would just drop off. He also was able to use a urinal with assistance, but family preferred to have him wear protective underwear at night. Mentation, so his dementia and behavior specifically, he had dementia with what we call behavior-related problems. He, would refuse to bathe or change his clothes. He would yell or strike out at anybody who was trying to help him. And he was confused enough that he didn't really know what the day, date, or month or year was. And he frequently confused his daughter for his ex-wife. Also spent much of the day sleeping, but he was up at night when the family all wanted to be and needed to be sleeping. Now he's come into your facility, and it says nursing facility. And his first thing that you see is he's saying, I want to go home. Next slide. So the first week in your care, under mentation, or first M, he's very unhappy. And he doesn't mind telling everybody he comes into contact with. He declines to participate in any of the activities you have lined up. So not just even the pleasurable ones, but things like basic activities of daily living, like bathing, changing his clothes. He's soiled. You need to change his undergarments. He's refusing. When he gets the food in front of him, you could try to cajole him to eat, and really just spits out the food, or he pushes his lips together. Or if actually somebody's offering the spoonful of food, he tries to hit at them. He only really wants sweets, soda, his plate lunch, which the family is bringing in for him to try to get him to eat. Under mobility, he keeps trying to get out of bed because he wants to have a smoke. He can't stand on his own without one person right by his side. And if he does ambulate, he needs a gait belt because even with his front wheel walker, he's somewhat unsteady. He appears to just be getting overall weaker. And since he came in a week ago, he's already lost another 4 pounds. Next slide. Under the medications, he's really not taking them. Maybe half of all the medication doses goes in. He's spitting those pills out. Even if they're crushed, he'll figure it out because he somehow seems to taste them in the food and will refuse to eat. His blood pressures are about 150/90 average, and he hates having his finger sticks done, so he curses at the staff, pushes them away when they attempt to do that. And really, you're only able to check his finger sticks about half of the time. His blood sugars are slightly elevated, 140 to 190 range every morning. And if that family is getting those treats in or that Pepsi, they're well over 200. And under what matters, he will tell you, I want to go home. It's like a prison here. The family is very concerned and expresses that to you because he's not happy and he's also losing weight. Your staff or the members that are helping with his care, they're concerned because he's such a fall risk. He appears malnourished and his diabetes and blood pressure don't seem under control. Next slide. So we need to create a care plan using our 4Ms for Mr. Chayana. Next slide. What are you going to do? So my suggestion is that we frame the rest of it around what matters. And that's really to start with our resident-centered wishes, or if he isn't able to tell us, then his family or those are his decision makers. What are their wishes? Well, he's told us what our wishes are. What are those?
He wants to go home.
I'm in prison. Let
can't
me
go
out.
home.
Yeah, he's pretty clear. Now his family is also concerned. What did they say when he was at home? They said, you know what? We don't want trouble. We kind of let him do what he wants because that's what makes him happy and keeps things, keeps everybody happy, really. So how do you meet the goals for the resident and his family? And then really for all of you and us as providers, how do we balance these goals or wishes, what matters to them, with his safety and well-being? This is a huge task. Any ideas? Has anybody met Mr. Chayana or somebody similar?
Maybe we can ask the family not to visit for a while.
Oh, okay. So maybe letting him get adjusted, is that your idea, or not to
Yes.
bring those treats?
Yes, that's one of those.
Okay. Other thoughts?
I'm sure you have experience with this kind of a person.
Oh, somebody said, oh, I like that. Find something he is interested in, right? He's not, what are his other interests besides Pepsi, plate lunch, and having a cigarette?
Playing cards.
If he
Same
is
con-
falling, maybe we can offer wheelchair.
Okay. Some other mode of transportation. Excellent. Sure. Anybody else?
Would you let him smoke?
No.
Maybe we can schedule his smoking like 1 in the morning and in afternoon, so that we can be attention with other residents
Sure.
if he wants it.
Yeah. So allowing, that's something that he's only asking for 2 a day, maybe 1 or 2. Yeah. Some people don't want to let him smoke. We know smoking's bad, right? But Mr. Tiana, maybe that's a compromise.
Make him happy.
Make him happy, absolutely.
If you don't want him to smoke, don't admit him in
Don't
your
admit it.
place. Yeah, don't admit in your place if you don't want them to smoke.
Sure. I think as you're suggesting, this is something maybe to have worked out a little bit before. If the family's going to say we want him to continue to smoke, and you have a no smoking household, or you have other residents on oxygen, you know, that's not going to go. So that's a good thought. Somebody else said something. I missed the chat there. There was another
Yeah,
comment.
there's a bunch in the chat.
Oh, I
there
can't
was
see.
one that said maybe not let him smoke in the house, but maybe outside the residence.
Mhm.
And another said maybe go drive him around. Maybe he'll be happier if he's outside in nature.
Sure.
And then Leticia said divert his attention to something that he would be interested in.
Oh.
So yeah, some really great suggestions.
Awesome. Yeah. Yeah, he's in a whole new setting. So finding something that, you know, matches what matches his capabilities and his interests. I'm really great. I like all that. How about the sweets? What are you going to do about those sweets and his diabetes?
Give him unsweetened candy.
Oh, yeah. Just awesome. Other treats.
Great idea.
Yeah. Oh, with sugar-free fruit or fruits. Awesome.
Yes.
Sherbet ice cream. Something tasty. Awesome. I like that. And really, as people at Mr. Gianna's 80s, bake sweets with less sugar. Oh yeah, cut that, right? You can cut the recipe in half of all that sugar, they say. Well, that's a good idea. They're saying baking sweets without all the sugar. And sometimes with older individuals like Mr. Gianna, we have a much more liberal view of how high their blood sugars can be. Hemoglobin A1C, which you know you're familiar with, is a way to track how the blood sugars are doing. And we're a little bit more liberal as people get older. So working that out with the family and meeting his goals. That's excellent. Were there other things in the chat? Yeah. Yep. Adjustment. Yeah. With all the distracting.
There was one more.
Yeah.
They were talking about in terms of smoking, slowly weaning him from his cigarettes and eating candy. He'll eventually get adjusted or forget in the long run.
Sure.
Great
Sure.
suggestion.
Right. Maybe make that transition easier. That's wonderful. Yeah. If he's engaged other places, maybe that's not an issue. That's excellent. What about advanced care planning? So the DPOA, those kinds of things. We have his looks like he's do not attempt resuscitation, no artificial nutrition or hydration. He doesn't want to go to the hospital. His family's goal for him is comfort care, just be comfortable. So while he might not be able to give us have the capacity to make very large decisions, he does have the capacity to tell you that he wants to smoke, that's enjoyable, what he likes to eat. But meeting those goals, I think, takes into the family and what they support. So it sounds like the daughter's really about being comfortable. So maybe allowing that occasional sweet or, alternate, and also allowing the smoking may meet this plan for them. Any other thoughts?
That definitely would be, hi, this is Juliana. It would be person-centered, especially if his advanced care planning had, it's not as a do not resuscitate, and that quality of life, and he enjoys his occasional cigarette, and he enjoys his occasional sweet. If you're towards the end of your life, and that's what a quality of life means to you, that's something that should be taken into account and respected, of course, within means, but that's really like person-centered. Those other options, the sugar-free, that's a way to like kind of a workaround for his want of eating that candy so it can be healthier for him. But, that is definitely a place of conversation for many, especially the family, when it comes to him being able to have capacity and make those decisions, what his wants really are versus what his needs are, I guess.
Mm-hmm.
So yeah, definitely.
That's a great point. That's a great point that we allow. Yeah. That we have a lot more, we're a lot more liberal with things that, that aren't directly harmful for his smoking. I mean, likely he has a lot of, if he's been a lifelong smoker, he likely has a lot of accumulated lung damage, and right, we're treating symptomatically. We never cure anybody of chronic obstructive pulmonary disease, but we manage the symptoms. I mean, if he gets to the point of needing oxygen, then we're going to have a new conversation perhaps, but about smoking and safety. But yeah, I think that's a great point. Thank you, Juliana. Any other thoughts on this balance for him?
Yeah, one of my thoughts also is, the family's really distressed that he's losing weight, but, they should know that, as he's kind of getting worse, he may eat less and less. And that's going to be a natural part of progression, and they should expect it. And it should be okay as long as he's comfortable.
Mm-hmm.
But of course, we'll do our best to try to give him foods that he will eat.
Mm-hmm. Okay, and maybe it's just a temporary, change, right? Right, as he's getting used to his new residence, and you're getting used to him, and under your care, there'll be something that will meet, in the middle. Okay, next slide. Okay, so under mentation. Next steps in the care plan for under mentation. So what are the issues? What are his issues regarding mood? Or we can look at his dementia behaviors, and how can we address these with what matters to him? So there's certain things that seem to be setting him off. He's in a prison, he's trapped, he wants to go home. He's got a lot of behaviors around the food or the medications that he's supposed to be ingesting. How do you tackle this one?
So, do we know if he's depressed? Is there a screen for that? Do we know how to screen?
Check with geriatrics, okay.
Right. Oh, I'll check with the caregivers or the PHQ too.
Yep. There she goes. Thanks, Juliana. That's right. I was on the call when everybody was turning in their PHQ2 discussion. Very useful. Very useful. Okay.
Yeah, I mean, part of his irritability and stuff, maybe he is depressed, and maybe we should try treating it. Do you remember how we treat depression with the non-drug strategies as well as possibly medications?
Oh, I like that. Angelina. Okay. Angelina said, bring some familiar things from home. Virginia's talking about get him involved in activities, but especially outdoor activities. So sunlight exposure, right? Don't let him sit in his room. Don't let him stay there. Oh, excellent. No, all non-pharmacologic management. Excellent ideas.
Yeah, remember all that behavioral activation strategies?
Okay.
Well, he was a construction worker,
Mhm.
right? Yeah,
Yes.
what kind of activities would we give him?
I'm not sure I'd give him a hammer. When he's like incorporating, okay, thank you. And said find out what he was like in his younger days, incorporate his hobbies, find out his likes and his dislikes. Excellent idea. Yeah. Appeal to those memories. Okay. What are you going to do about his behaviors? How are you going to manage those? He's spitting, he's cursing, he's
Oh, Juliana says building blocks. Yeah.
oh, I
you
like that.
build. Yeah.
It's coming. They also said regarding his dementia behaviors, schedule follow-up with his physician that address both mood and behaviors. Structure, yeah, schedule every day, something that he can know this is what's going to happen. Is this what you mean, Juliana? Like the day's going to start out with a bath or whatever it is, but there's a structure or schedule.
Exactly. If you have a structured schedule, he's not going to be confused if there's something new popping up. He's not going to know what to expect every day, become comfortable with that schedule and not be so afraid and confused at times if he forgets, because it'll come right back because he's accustomed to doing that memory.
Absolutely.
Oh.
When you
watch the remodeling channel, watch with him. That's so much fun, isn't it?
Yes. Yeah, it's great. If he was into sports, right? Put on the sports channel. But I like people have already said that. Find out what he liked. What was he interested in? What was he? Yeah. So distraction, right? So the moods. I think people are identifying like what are those triggers? What sets him off? You know, crushing meds and putting him in some food. Well, maybe he needs that sweet food to get those medications in. And it will go down in one mouthful, right? Versus trying to get it into that oatmeal that he's really never going to eat. Yeah, but somebody said sherbet ice cream or something, but something that's going to make the medicine be ingested. Okay. Distraction also for behaviors, right? Whoop. And then I can't see. Oh, somebody just joined. So distraction also for behaviors, other things. I mean, if mealtime is more a social event, if everybody else is eating, there's that queuing, maybe that would help. Offering favorite foods or something else I can think of. Being okay that there might be one big meal of the day and there's other smaller meals, might help get nutrition into them. All great suggestions. Anything else in the chat? How you're going to manage his?
I don't see anything else.
Okay. I have a question. How do you get him to change his clothes? How do you get somebody resistant? Okay. Angelina talked about getting the family involved in his care plan. What are they willing to do?
Oh, holo holo every Saturday. I love it.
Any tricks to getting him to change his clothes or his soiled undergarments? Does anybody have any tricks?
I don't know. I'm thinking, motivation to go out and smoke.
Oh,
Did I say that?
it's a carrot. After you get changed, after you have your shower, we're gonna have that Pepsi, or we're gonna have that. Yeah, have your smoke. I like that. Okay. Why don't we go on to the next M? Mobility. Oh, what are his issues regarding mobility?
I just want to say,
Mhm.
he wants to go home because nothing is familiar. But once he develops a rapport with the people who care about making him happy, it might feel more like home to him.
Mhm.
And I think that's the idea that we want to strive for.
Mhm. And I think somebody made a great suggestion, having familiar objects there that he's, reminders. Right. Help. Okay, looking at his mobility issues, what I heard there, people were afraid, the people caring for him are afraid he's going to fall down. How are you going to address these? And he's used to just furniture surfing at home, not using any device. So he thinks he can get out of bed on his own, but really not safe. Here we go. Reminding him to call when he needs help. Yep. And responding, right? When he calls, that somebody comes. Yeah, that's great. Any other ways that you can keep his function up and keep him involved, but yet keep him safe? DME, more DME, yep. So assistive devices, things that make him as independent, what he can do for himself, and that he can use. Does he need a grabber tool to get something at the end of his bed or from his side table? I like that.
I was remembering that the food falls off of his spoon. So I don't know. At some point, sometimes we just do finger foods. We just scrap the spoon. Maybe we just
No
eat with
need.
your fingers.
Absolutely. And that gives him control, right? Over what's going in or, yeah. I like that. But you're busy with another resident in another room or something else. How are we going to, and he wants to get out of bed or needs something or tries to get out of bed. Ways to keep him safe. Bed alarm, maybe. Yeah, perhaps. Yeah.
Or maybe just walk him. Like, don't wait till he calls you. Just say, okay, every day after meals, we walk.
Yeah.
Maybe a baby monitor.
Baby monitor. Yeah. So you're somewhere else and you can still hear the rustling. I know some people have cameras, right? If that's acceptable to the family, but to have cameras.
They have to sign, the family needs to sign if they
Yeah.
want that to be surveyed.
Absolutely. Right. If the family accepts that. Absolutely.
Yes. So that you know what they're doing inside the room.
Yeah. I've seen some people use a bell that, then the individual has some control. They're not always yelling out, but they actually have a bell or some other device to call for help or call for assistance. not quite so loud as the bed alarm, if they can manage. And going back to what Juliana said, and I think Dr. Wen, is that if there's a schedule that he knows he's going to get up for certain activities and, you know, he's getting some mobilization, you're keeping him strong, anticipate his needs. Oh, I like that. Excellent. Yeah. He always goes to the bathroom right after breakfast. Right? Can we ask his doctor to refer physical therapy? And then and for strengthening and good and then the caregivers actually, once physical therapy is over, right, you have a whole home exercise program that they give to you to try to get his strength back up. Excellent. Okay. Well, I think those are great suggestions. Anybody else? All right. There are other DME, I think, as Juliana said, but there are things like floor mats, you know, half rails that he can reposition himself in bed, you know, maybe not get out of it, but even maybe just even reposition himself if he's in bed at that point. Yeah, but floor mats or that would hopefully help prevent injury. Having the bed, if it's a hospital type bed. Mm-hmm.
Oops, sorry to interrupt. I think there was a great comment asking the doctor to refer for physical therapy for strengthening, so caregivers can assist with those exercises at home. Yeah, great suggestion.
Absolutely, absolutely. I'm at the VA and do home-based primary care, and we actually have a Zoom spin class and so the family will set up the little pedal bike, right? And then there's all the paces on the screen and people participate in a virtual spin class, right? Just using a foot pedal bike to keep up the lower extremity strength. So that's been kind of successful, but setting up your own spin class, something like that. Okay. And then the next one, let's move on to, I think, medications. Here we go. So now he's refusing to take them, right? We know he's spitting them out. You've crushed them. You're trying to hide them. And we're a little bit concerned, you know, perhaps about diabetes control, or what are his issues regarding medications and how might we address these with what matters to him? And is this consistent with his advanced care planning wishes? Remember, it's to be comfortable. We talked about quality of life. What do you want to do about medications in his care plan? Oh, the pudding. Okay, that's right. Get it and put it in something he'll eat, like the sweets. Oh, that's okay. I'll make sure you ask if these are crushable tablets or capsules or whatever they're. Or make sure they are on that crushable list. Sometimes when things are crushed. Oops, sorry.
Like chocolate, there's chocolate bowel mitts. and gummies, right? Of all kinds.
Sometimes I worry one thing about crushing, he may be spitting out because it doesn't taste good when it's crushed, right? There's actually a flavor. And some people say, oh, he figured that out, that the medication's in there because even it was his favorite food, but it tastes different because of the crushed, you know, whatever. Somebody said something, I missed that last chat.
Give time to calm down. And if he refuses, then come back a few minutes and try again. Absolutely. Right. Don't push it.
Yeah. Oh, I like that. Mary Jane said, earn his trust. So about the relationship.
You know, I like it. You know, if he's got like 10 minutes and he's not taking half the time, then, you know, it's time to look at the medicines and figure out, well, does it have to be given twice a day, 3 times a day? Can I simplify it? Maybe the pharmacy can give me an idea so that he doesn't have to, I don't have to bother him so many times a day with medications. Right. Some way to simplify it.
give ultimatum.
Well, what do you think? How many people think that works? I'm afraid it might only work sometimes.
Yeah, absolutely. Depends on the situation. Just building off what Dr. Wen said is maybe looking at is the comfort plan for him, if that's the goal in his advanced care planning wishes, and for the families is durable power of attorney for healthcare. If they stated that's what it is, not just simplifying the medications, but there are ones that we're going to eliminate because the benefit of those medications isn't, he may not have that long a lifespan to actually benefit from those, and accepting maybe higher values for his blood sugars. And so that's a discussion maybe to have with family, physician. So if his blood sugar is routinely 180 or 190, maybe that's okay for him. And do we really have to stick his finger that many times? Maybe we could cut back or not do it at all. I missed that last one. We may have to
understand why he or she may not want to take the meds. Some meds really taste terrible.
Yeah.
And sometimes if you ask the pharmacy, they know which ones taste better than others.
Oh, so maybe changing to a different formula. So this is if the client's refusing, maybe there's a prescription that could be injected. Maybe it's doesn't. Maybe there's a liquid form that might taste better. Or something else. But that's a great suggestion. Is there an alternative form? Is there a long-acting formulation that can be given? Something else if it's that critical. Great
There's
suggestion.
patches too. There's there's for blood pressure. Sometimes I just resort to a nitro patch, right? If they won't take anything else for their blood pressure.
Yeah.
And pain, well, we could put a patch for that too, and we could put creams for that.
Yeah.
Get Voltaren cream, all kinds.
Okay. All right. Why don't we go on to the next? Have we covered all the forums? We covered it.
Yay.
Thank you,
Yeah.
everybody. Those are really good suggestions. I think this is an incredibly challenging situation, especially when you first meet somebody and they first come under your care. It's such a period of adjustment. Can be months, correct, to really figure out and then work with the rest of the team caring for them, but incorporating pharmacy provider, whether APRN or physician, whoever the case manager is, and family being part of that team, as somebody really pointed out, understanding what their goals are and having them be part of your team. Thank you.
Great. Yeah, so next slide, just a reminder that we are looking for 3 things from you, right? Did they complete that general power of attorney form and designate a healthcare power of attorney? Did they complete that advanced care directive and say what is it that they want? Maybe they, their wishes for end of life care. They don't want resuscitation or they don't want tube feedings. And then there's number 3 is that post form. So those 3 things, just make sure every single resident in your facility has 1, 2, and 3. So next slide. So Michaela is not on today. Unfortunately, I had to miss, but she will be sending you a link. And if you haven't done it already, please do. How many residents do you have? And how many have that power of attorney? How many residents, out of how many residents, how many have that advanced care planning documented? And then out of all your residents, how many have a post form? Our goal really is to have 100%, right? If we can. And that means we're helping to meet all of our residents' wishes. And so we can really be person-centered. And today, yeah, so today, hopefully we'll continue to think about their quality of life as part of that advanced care planning and making everything all about them and making them all about their wishes and meeting their wants and the desires, keep them happy, make it feel like it's home for them. And that takes a great deal of creativity, and you guys are very, very creative, and you can brainstorm with each other too, and the rest of their other teams and the doctors and the pharmacists to figure out how to be creative to do this for our residents that we care for. And I'm just gonna, next slide, I'm gonna put this up for Michaela. She has, as usual, she has these office hours she will hold for tomorrow, 10 a.m. and 2 p.m. in case you have questions, and next Monday as well. So thank you very much. Does anybody want to share any stories or any thoughts? Or more questions? Yes, thank you for a great presentation, Dr. Lubomir. Good case, very relatable. Okay, so how's everybody? Oh yeah, the first 2 weeks of admission is the hardest part. Absolutely. I always tell families that, yeah, it's the 2 to 4 weeks, the first month, right? But the more time you put in at the beginning, right, to really, really, really get to know them, that pays off. Yes, yes. The first month, definitely, yes. Always go back to what matters to them. Okay. So hopefully everybody is doing something to also do what matters to you too. And taking care of yourselves. All right. So I think John put in a link a little bit earlier to do the evaluation forms. So make sure you click on that link, and that way you can get your continuing education credits. Okay. We'd love you to get the credit for listening and joining and participating. And starting next month, we're going to start a whole new series on mobility and function and falls, and seeing what we can do to, get everybody a little more functional. That'll be also a really good series. So yes, happy belated Mama's Day to everyone. Enjoy the rest of May. Okay, bye.
Bye.